Good afternoon, and welcome to our quarterly webcast for the Methodist DEBAKEY Cardiovascular Journal. I'm Miguel Quiñones, the editor-in-chief of the journal, and today our webcast is going to be in the topic of the cardiovascular complications of COVID-19, which is the main topic of our current issue of the journal. I'm very much appreciative of the work that Dr. Mouaz Al-Mallah did as the guest editor for this issue. And as you will see, if you look at it and read it, there's a lot of amazing, good articles reviewing all of the cardiovascular complications that have been observed with COVID-19. Today, Dr. Al-Mallah is going to be running the webcast, and he has a lot of the authors of the articles to have a dialogue with and answer questions. Without any much delay, I'll give you Dr. Al-Mallah. Thank you.
Good afternoon, everyone, and thanks for joining us. I'm very excited to be here today with multiple colleagues who joined me in co-authoring multiple review articles in this special issue, which is dedicated to the to COVID-19 and the heart. This issue was just published, and we have the print copy here, and we're gonna have to review some articles that were the published review articles that cover the different aspects of cardiovascular care during the pandemic, but also at the same time the specific cardiovascular complications from COVID-19. We're gonna have it more of a dialogue kind of session of CV Live. So we welcome your questions, and I would like to invite everyone to send your questions on the web. You can go to paulev.com, enter DEBAKEY, and then send your question, or you can text DEBAKEY to 37607 and text in your message. So we're going to start with Dr. Sachin Goel. Dr. Goel is an interventional cardiologist and structural interventionalist also in our practice in Houston Methodist DEBAKEY Heart and Vascular Center. And he contributed a very important article about the management of patients with acute coronary syndrome during the pandemic. And as you know, we are now in the middle of a surge of COVID-19. I would like to start with Dr. Goel telling us about how is COVID-19 affecting our regular cardiovascular operations. How are we treating patients with acute coronary syndrome when we have everyone testing positive and the hospital is full of COVID patients?
Thank you, Mouaz, for inviting me. Yes, this is a very timely topic and has been, throughout the last 2 years of the pandemic. As you know, the acute coronary syndromes patients are, the high-risk patients, and this has posed challenges, over the last 2 years, starting with the first wave, when we saw a decrease in the incidence of acute coronary syndrome, surprisingly. And, that was related to many patients not showing up into the emergency rooms or presenting themselves to the hospital for fear of contracting COVID. Subsequently, with improved awareness of this and public messaging, we haven't seen a decline in subsequent surges. And, the COVID pandemic has really posed unique challenges in not only managing, but also diagnosing these patients, managing, of course, in the cath lab. For instance, in the initial wave of the COVID, initial waves, I should say, we saw an increased risk of delayed presentation, delayed complications of acute myocardial infarction in patients with acute coronary syndrome. That was in part related to the delayed presentation. Several registries have looked at this over the last 2 years. For example, the COVID ACS registry, it's a retrospective registry including patients from about 50 centers. they compared COVID ACS patients, the ACS patients presenting in the COVID era to the ACS patients in the pre-COVID era. And several important findings from that study were summarized. First of all, compared with the pre-COVID era, there were significant delays in patients seeking medical care, not surprisingly, and longer door-to-balloon times in the COVID STEMI patients. There was significantly higher rates of cardiogenic shock and requirement for ICU admission and ventilatory or hemodynamic support in these patients. There was almost a quadrupling of in-hospital mortality compared to the pre-COVID cohort patients. For example, the mortality in the COVID STEMI patients was about 23% compared to about 6% in the pre-COVID era. So that was a staggering, increase in mortality compared to the pre-COVID times. And they were also found to be younger and carried a greater burden of comorbidities. So these were some of the differences we found in the ACS patients presenting in the COVID era when compared to the pre-COVID population.
So that's a very important point, and you mentioned, you touched base a little bit on the issues related to the ICU and requirement for admission, and we're going to cover that later on with Dr. Masud. But you also mentioned about diagnosis, and there are many patients who continue to come into the emergency room with chest pain, and we want to try to make a diagnosis of their chest pain. And how has there been any major changes during the COVID era compared to prior to the COVID era?
Yeah, that's a very important question, Mouaz. As you know, in the initial phases, there was a shortage or sort of deficiency of PPEs, and PPEs was really on top of everyone's minds. And the sort of the paradigm, at least in our practice, has shifted from of course, the patients with STEMIs, still the gold standard is primary PCI. You assume everybody is COVID positive until proven otherwise. In the STEMI situations, obviously, there's no time to wait and test for the COVID situation. But in the non-STEMI or the non-ST elevation ACS patients, there is, a great deal of, sort of a stepwise approach that we can take in these patients. First of all patients presenting with acute chest pain or any patient being admitted to the hospital is tested for COVID as a matter of policy. And then, in addition to history and careful physical exam, EKG, biomarkers, a good point of care ultrasound can be extremely helpful in these patients in assessing the LV wall motion abnormalities to see if, the wall motion abnormalities are generalized or localized. In addition to ACS, of course, the troponin elevations in these patients can also be from non-ACS etiologies, such as stress cardiomyopathy, myocarditis, coronary spasm, and type 2 myocardial infarctions, such as those related to respiratory failure in the setting of coronary disease or arrhythmias. So there's a whole host of, whole list of etiologies which can be associated with elevated troponins. So I think a good focus history, physical, good clinical exam, corroborating all the findings, a good point of care ultrasound is very important in sort of risk stratifying these patients as to which patients truly are high-risk patients and which patients are maybe not as high risk for an acute coronary syndrome or a plaque rupture. In addition, I think coronary CTA has become increasingly utilized in identifying these patients, since we are getting better and better with CT imaging in identifying patients that are at high risk for plaque rupture and acute MI. In addition, in the past, stress testing was utilized, but with stress testing, there is increased risk of aerosolizing exposure, and so perhaps that is one of the reasons the stress testing or the exercise stress testing in the acute chest pain presentation has gone down significantly, and cardiac CT imaging has gone up over the last couple of years. So these are some of the changes we've seen in acute chest pain testing when patients present to our ERs and hospitals.
Absolutely, and if we can share the slides from the control room, I mean, many of these patients, they do have actually an indication to get a chest CT, and by gating it, we are able to assess the coronary, especially if they have maltroponin elevation. But also stress testing, we continue to do a lot of stress testing for these patients, even in the acute phase, but we try to triage these patients and make sure that this is the appropriate indication. And this is, for example, a patient with pneumonia, but they required the stress testing because they couldn't be assessed by CT. And we did it with the cardiac PET, where you can see all these inflammatory changes in the lungs, but also you can see rubidium PET with significant uptake in the lungs in this kind of advanced case of COVID-19 infection. So I do share, and this is something we contributed, my research team added into the imaging of these patients in the acute phase, and we try to protect not only the patient but also protect our staff. And we want to make sure that we added here a new factor, not the most, we want to do the most accurate test, we want to do the most efficient test, but also the safest test for our patients and for our staff. Thank you, Sachin. And I want to move on to Dr. Man Malafji, really to follow up from a point that Dr. Goel just mentioned, which is the myocarditis part. I know that Dr. Malafji is one of our multimodality imagers, and he's the director of cardiovascular MRI research. And Dr. Malafji contributed an article about the role of cardiac MRI in this thought to be myocarditis in these cases, and how often, how common is it? And I know that you've done some studies about this. Can you tell us about your review article here, and what did you find also?
Thank you, Dr. Al-Mallah. And like Dr. Goel alluded to, many of the patients who are hospitalized with acute COVID, particularly the severe cases, will have their troponin checked, just like almost any other patient that comes into the hospital. And the rate of troponin elevation has been quite high, particularly in the severe cases. Myocarditis related to COVID has been really looked into since the early days of the pandemic as a potential etiology. The challenge has been the isolation, the relative lack of PPE early in the pandemic, and investigating these patients, whether it's doing a myocardial biopsy or a cardiac MRI while they're still acutely infected. So many of the patients went on relatively under-investigated or looked at, and now we have a major task ahead of us as to those patients who recovered and had a troponin abnormality or had some other cardiac exam or testing findings, whether this was related to, quote, myocarditis or some other cardiac injury. The second challenge is most of the patients who get COVID and become severely ill have multiple cardiovascular risk factors. So they are quite likely to have had a silent MI. They're quite likely to have underlying obstructive coronary disease. And the myocarditis prevalence, while initially thought to be high, appears to be a lot less common than when initially thought. So the majority of abnormalities that are seen on MRI appear to be ischemic related injuries rather than the classic patterns we see on in myocarditis cases. There is still a good number of cases that now we've really resolved to terming or calling non-ischemic myocardial injury, and that is really to try to differentiate it from the classic myocarditis pattern that we see on MRI. The virus appears to be different than the traditional cases of adenovirus and herpes virus that were traditionally associated with myocarditis, in that the coronavirus itself doesn't seem to have as much cardiac tropism as compared to other viruses that traditionally cause myocarditis. So there's certainly been cases where the virus has been described and seen on electronic microscopy in the cardiac interstitium, but the classic cardiac direct toxicity by the virus doesn't seem to be as prevalent compared to others.
And if I may ask the control to share the slides that we have. So this is the image of the cardiac MRI of the patient that you included in your article. So can you tell us, like in a patient who had an elevated troponin, can you walk our audience about through this MRI and what you see there?
Yes, I don't have the slide in front of me, but I'll go by memory. So in many of the patients who had these troponin abnormalities or have persistent symptoms after recovering, cardiac MRI is a reasonable test to pursue to try to identify any myocardial scarring or injury. And the way we do this is after administering gadolinium contrast, the imaging that's obtained will show healthy normal myocardium as dark or black, whereas areas of fibrosis, injury, inflammation, or collagen scar will have an enhancement that you can see on the slide, where it should have a little bit of enhancement in the mid-inferior wall. I don't know if you can point to it. This usually indicates a prior myocardial injury, but what I really want to sort of drive home is that it's not necessarily a slam dunk for us to blame coronavirus as the cause for this, because many people will have had other illnesses before. We don't have, a lot of research on how other viral infections will affect the heart in terms of, severe influenza viral infections. And, these MRI abnormalities, while still very important for us to study the impact of, at this point are still in a gray zone, to be honest with you.
All right. Well, thank you, man. And again, I want to invite our audience to send questions. You can go to paulev.com and enter DEBAKEY and respond to the questions. And also you can text to DEBAKEY to 37607 and then type in your message. Thank you, man, for mentioning this. And we were talking about more of the sicker patients who were entered to the admitted to the intensive care unit, and we're lucky to have Dr. Faisal Masud, who's the director of our ICU and critical care program here at Houston Methodist, and he contributed an article about the changing face of the ICU during the pandemic. And obviously we wanted to protect our staff. We ran through times where we didn't have enough PPEs. And how did the ICU differ, Dr. Masud, between the pre-COVID era and after COVID?
Thank you, Dr. Mouaz. Thank you for inviting me to this group. Clearly, this was the critical care team where, we were trained all of our life for this thing. We didn't want it to happen, but this happened, and it is actually still happening. It's almost 2 years. We had our first patient admitted to our ICU March 6, 2020. So what's been happening in the last 2 years is that we had a myriad of challenges. We had a disease which we were learning on the job. We had a disease which was impacting healthcare workers, patients. There was an alarming number of deaths from coming reports from China, from Italy, from New York. And then we have a barrage of patients. So if you see some of our data and slides, you'll see that we had an increasing number of ICU admissions. And not only that we had a whole host of patients who still needed critical care. So as Dr. Goel mentioned, our emergency room were flooded, our ICUs are flooded, and we had to keep on expanding in the number of ICU beds. We had to protect the patients. We had to protect the healthcare teams. And, the disease, which had in some of the reported cases, death rate up to about 50%. So if you see in this graph, we had to keep on increasing the ICU capacity, and we had to go up. And as you see different curves in different waves, the number went up to 184 beds from ICU. Our system ICU capacity was about around 350. So as you can see, 50% of the capacity was increased. With all that being said, some of the data that you're seeing is that the mortality will come from a regular ICU patient to a COVID ICU patient, as you can see, was up to almost about 22%. The length of stay was higher. But something which I can tell you is that some of the reported literature showed mortality about 40 to 75%. So I think we did a pretty decent job of keeping them alive. As you can see, this data shows some of the patient, almost 20% needed ICU, a small percentage needed ECMO. This is data about some of the things which in terms of volume. If you see the next slides, which is a lot more detailed, is really talks about, if you can see, is we have to provide patient-centered care, developing algorithm and therapies, because whether to prone, not prone, to put intubate, not intubate, put a mask on, and especially if the patient was coding, should we just break all the barriers, jump into the use and try to do the CPR, exposing potentially 9 people, and some of them may not make it. So those are the algorithms we had to do. We had to get ethics involved. We had to expand our ICU capacity. We were very fortunate that we had launched our tele or virtual ICU in February of 2020. So we had to again double up. That allowed us to expand care in our ICU, that protected from our PPE. So not everybody had to be in the unit. We had to convert IMUs to ICU. We had to provide care to the ED with mobile carts. We had to dynamically changing all of the stuff. And for about a 6-week team, we had to have non-intensive take care of ICU patients, which are not COVID. So all of these things were happening. With that, expanding, learning, and communicating all across from patient being transferred. If you go to the next slide, this will give you a little bit of insight to some of the things. The pumps were outside the ICUs. These patients were on novel therapies. We have to manage them. We have to protect them from getting, hyperglycemic. So the glucose monitor were outside also in some of the slide. We had to keep on evolving our ECMO. Just to give you a little bit of insight, we did about 100 ECMO cases in 2020 and about in 2021, more than about 100. Unfortunately, because so much was needed that we turned down 200 ECMO from all over the country. The slide that you're seeing is showing some of the innovations. And in the next slide, you'll see some of the algorithm for ECMO utilization. With all of this being said, if you look at it from a critical case standpoint, a patient is critically ill, no matter what the disease label is. So with that being said, we had to provide care for all the STEMIs, all the transplants, all the VADs, all the other patient-wise. And unfortunately, that did impact the care timing and delivery. And the slide that you're seeing is ECMO algorithm, because ECMO is a very high-risk resource. And, we had to revise our guidelines who can get ECMO, because we realized pretty soon after 6 months of data that if you are 65 and above and you are COVID and you required a VV ECMO, pretty much mortality was 99%. So we have to update those guidelines. With all of this said, the interesting which was never faced was the infodemic. So not only we were dealing with pandemic, but infodemic. What is infodemic? Misleading or wrong information. So people were asking for therapies from us, which was by Google. So people were following Google doctor, WhatsApp doctor, and my uncle, my cousin. So we were dealing with that, and on top of that, vaccination impact wise. So we've seen a whole change of vaccination impact. Now we are in the 5th surge, and I can tell you right now, people who got fully vaccinated or boosted are a very small minority. Majority of my patients in the ICU right now are people who are not vaccinated or partially vaccinated. And we have to look at the social disparities also. Unfortunately, we saw that a lot more patients were from underserved communities and for having a lot of comorbidities, diabetic, hypertensive, coronary disease. These are the patients getting more sicker. So if you look at it, vaccination have proven to be one of the fully vaccinated, including booster, have proven to the best defense possible. There are novel therapies, but they're not, so widely available. So critical care evolved in the last 2 years in no way, and the lessons learned, how to scale up, how to have non-intensive take care of patients, how to really manage cardiac-related, lung-related issues, because they're all interrelated, how to triage resources, how on top of that, families could not be in the ICU rooms. That was a big connect. So we use our virtual ICU to connect families to the patient. We did, our fellows can, and other attendings and can do manage patient with screens outside. Our virtual physician and nurses can help triage cases. So these are some of just a highlight of some of the things which you have to do. And not only that, we were actively engaging people inside Houston, Texas, all over the world with all the learn that we're doing it. So I think and some of the lessons that we learned has allowed us to manage better right now compared to 2 years ago. So This is just a brief overlight.
And I have to say, if I want to take a moment just to really thank you for your leadership in this, dealing with all these sick patients, and all the healthcare workers, from physicians, nurses, everyone who works in healthcare, for their support and hard work. I know many of them are burned out during this pandemic, and there are a lot of strain and pressure on them, and they are the real heroes, and they deserve all our respect here. But I want to touch on one point that you raised, which is this infodemic, and we kind of covered it on the way ahead, because there are a lot of misinformation campaigns that are going on social media, and I want to open it to everyone, actually, to say, I mean, how do we tackle that? I mean, patients are getting their information from Google. Most often it's not accurate. Social media, I'm sure all of you received some videos from quote-unquote experts who are talking non-science, and the question is, how do you tackle that? And it's open for everyone. Maybe I'll start with Dr. Masud, and then Dr. Quiñones, if you want to say anything, or Dr. Cook.
So, the most commonly were the therapies which have not been approved by FDA. Ivermectin, hydrochloroquine, about non-effectiveness of vaccines. The best way is you talk with people who have been misled. So you don't talk down to them, you talk with them. You engage them. You try to build the best evidence possible. And at the end of the day, believe it or not, a lot of time I had a conversation that this is what I'm doing for my wife, my children, myself. That's the best criteria I can tell you. This is what I'm doing for my family. I can't tell you anything more than that, because at some point, if they choose to listen or not, and you try to direct them to the best evidence-based practice and encourage them to look at the source of information. Okay, that's the thing. So I'm going to stop over here. I'll bring the other talk.
And Miguel, if you want to add something on this, or anyone else from the colleagues.
Yeah, I completely agree with Masud in what he said, and I kind of use a similar approach. I try to tell my patients, or even friends in social gatherings when they bring this up, it's, look, I have spent 4 decades in science and academic medicine, and we have learned a lot during those 40 years. We have learned a lot of things we thought were therapeutic, have fell down. We have learned about the importance of controlled trials. And with COVID, we're trying to follow the same approach. We're trying to do controlled trials and not just use anecdotes. So when you read things in Google or anywhere, if it's coming from a well-done controlled trial, backed up by science, published in reputable journals, that's something you may want to read and follow. But if it's the rest of the other stories, just be very critical of it. A lot can be said. There's a placebo effect that we can never understand well unless we do controlled trials. So I try to use that approach with patients, and I definitely do the same thing Masud did. This is what I do for myself, and I do for my wife and my children, my family. You get a 50% take on it. There's still 50% of people that still continue to go with the social media and my cousin and my body and everything else.
If I could add
Sure.
one thing to those great comments, Dr. Al-Mallah. First of all, thank you for bringing us all together. It was an important issue in a very excellent journal now under the management of Dr. Quiñones, and I'm proud to be part of it. One thing I can speak to with respect to misperceptions is the misperception that messenger RNA vaccines are new and scary. Yes, this is the first mRNA drug to be approved, the 2 that have been approved, the first mRNA drugs to be approved and used widely. But we've known about messenger RNA since the 1960s. They were first used in animal models as therapeutics in 1990s. And each of the major RNA therapeutic companies have dozens of trials of vaccines for cancer, for example, that predated the work with the COVID vaccine. So mRNA's been around, the mRNA vaccines have been around. They've been tested in humans before they were applied for COVID-19. So very safe vaccine.
Absolutely.
John, I really appreciate those comments. In fact, we probably should videotape you and put you out there for everybody to listen to those comments. And in fact, when patients ask me about the vaccine and they are concerned about it, I often quote you. I actually mention to the patients that we have you in our institution and that you've done amazing work with it, and that in fact these vaccines are potentially the next level of therapy for cancer and even cardiovascular diseases. But I think the public needs to know more about this. There's a lot of misinformation out there relating the risk of the vaccine. So thank you for those comments.
Absolutely, and thanks Miguel and John for your comments. But also at the same time, it sounds to me like the scientific community also, we kind of sometimes rushed some investigations, at least on the diagnosis side. And I'm receiving 4 questions so far, all about myocarditis. It looks like we alerted people, so I'm gonna send them your way, man, because it looks like we scared people with myocarditis. And the questions are like, how are we diagnosing myocarditis? Is this a sequelae of every COVID? So if I got COVID, and there are millions in the United States who got COVID, does that mean that even if it is 1%, now we're almost like 500,000 myocarditis cases? Or what's going on with myocarditis? Can you speak up a little bit about it and maybe assure people at least that this is not as common, and some of the publications, at least in that area, were kind of rushed and not as much?
Mouaz, if I can also add, man, to comment on, because I hear this from many of my patients, and actually for us in the outpatient clinic area. So we see patients that already had COVID. So many of my patients come back, they had COVID 2 months ago, 3 months ago. And they're still concerned with everything they're hearing about the lingering cardiovascular effects. So clinicians seeing patients as an outpatient, is there any recommendations or word of wisdom as to any type of diagnostic screening that these patients should have at 4 months or 6 months or sometime?
Okay.
Number 1, to pick up disease, and number 2, to reassure them that maybe they're okay. I mean, does everybody needs an echo 4 months later? Does everyone needs a vascular ultrasound study? So a few hints on that might be very helpful for those of us who are seeing patients in the clinic after they have had COVID.
So I'm going to direct this question to Man, and then we're going to go to John Cook and the endothelium story with COVID.
Okay, I have a long road ahead of me, but I'll try to address all of them. So in terms of myocarditis is a clinical diagnosis obtained with a good history, an exam, and supportive findings from echo, EKG, labs, and MRI testing also. The incidence of myocarditis after a mild or moderate case of COVID is going to be very low. I will give you an example study that came out recently that I think kind of trumps all of the prior studies that came before that. To give a little bit of context, about a year ago, some data showed significant percentages in the order of 60 to 70% of, quote, MRI abnormalities in those who recovered from COVID. But the methodology and the definition of abnormalities was a little bit loose, and there was quite a bit of controversy. So we have much better quality studies now. And for example, in a recent study that looked at healthcare workers and followed a large group in the UK, they looked at those who eventually got COVID versus a control group that is matched for age, sex, ethnicity, and comorbidities. And essentially, long story short, the incidence of MRI abnormalities to suggest myocarditis was the same between those who had COVID and those who didn't have COVID. That's when it comes to those who had a mild case or moderate case and didn't need to be hospitalized. Now, those who need to be hospitalized and those who had, abnormalities where their troponin was elevated or they had LV dysfunction on their echo, certainly are worthwhile to investigate after they recover. whether it's COVID that caused that or not is going to be difficult, because these are the people who have underlying coronary disease, who will have underlying hypertension and diabetes. So it's tough to blame COVID for it, because they're likely to have had underlying abnormalities that's going to be hard to separate COVID from prior to COVID. So in terms of whether the patient needs to be screened or tested after recovering from COVID after a few months or so, I think it'll really depend on clinical judgment. For those who have persistent symptoms in the way of chest pain, tachycardia, shortness of breath, and we've all seen so many, unfortunately, of these patients, I think they're definitely worthwhile to look at. I think it'll depend on the physician's judgment how to test them first and how to approach them. It'll probably begin with something simpler in the order of EKG, exam, labs, and echocardiography, with select use of MRI afterwards. For those who had a severe case and had a troponin injury that went undiagnosed or unclarified, I think it's worthwhile to pursue an MRI.
All right, so these are very important. So it very much depends on the residual symptoms, and I want to use this to move on to Dr. Cook, who is the chairman of our cardiac sciences department, who also contributed a very important article about the endotheliopathy that we see with COVID. And this may potentially be implicated in some of these lingering symptoms in these patients. So Dr. Cook, what have you learned about endothelium and COVID? Is COVID treating the endothelium differently?
Thank you, Mouaz, for asking me to speak to this issue. I do think that an endotheliopathy may play a role in many, if not all, of the acute manifestations of COVID-19, as well as the long COVID symptoms. I could give you a role for the endothelium in just about all of the manifestations, from COVID toe to brain fog that occurs with COVID-19. Because the endothelium, of course, is this delicate film of tissue that invests all of our blood vessels, and it plays such an important role in perfusion of our organs, and plays such an important role in the interactions of the circulating blood elements with the vessel wall, and plays such an important role in the modifying the underlying vascular smooth muscle tone, its constriction, its structure. And the permeability of the endothelium also plays an important role in organ function. So the primary problems that seem to be occurring with COVID-19 and the endothelium is that the endothelium becomes more adhesive for leukocytes. The inflammatory cytokines that are floating around in the bloodstream of someone with COVID-19, they act on the endothelium to make the endothelium more like Velcro. Normally, the endothelium is like Teflon. It's a barrier against thrombosis and inflammation. But with the inflammatory cytokines, you get these adhesion molecules and chemokines that permit thrombosis and inflammation to occur. So that could play a lot of the role in the thrombosis, deep venous thrombosis that occurs, in the myocarditis that occurs in patients with if you have an inflamed endothelium, an activated endothelium, you're going to get leukocytes invading whatever that tissue is, whether it's the lung or the heart. The endothelium is kind of the doormat that allows the entrance of those leukocytes. And finally, without going on too much further, Dr. Al-Mallah, I would say that long COVID, I think there's a role for the endothelium there as well, because the endothelial permeability is altered by COVID-19. Endothelial permeability is increased, and that increase in endothelial permeability could increase intracerebral pressures with increased interstitial fluid occurring as a result. Now, can we do anything clinically with that information? there are trials looking at agents that can enhance the endothelial functions like nitric oxide. Nitric oxide has not only a vasodilatory effect on blood vessels, improving perfusion, but has an antiviral effect as well. An anti-inflammatory effect prevents things from sticking to the vessel wall. So I'm looking on with interest at some of these trials that are going on to see if enhancing nitric oxide production is useful. In the meantime, I'm trying to keep my endothelium healthy. And the way to do that is everything we do in cardiovascular, keep your cholesterol low, treat your diabetes, treat your blood pressure. A lot of drugs improve endothelial function that reduce cardiovascular events like statins, ACE inhibitors, ARBs. If you have risk factors, treat them. That keeps your endothelium healthy. And there's no data yet for it, but I am taking nitric oxide supplements.
All right. Well, we hope that we can...
One quick question, John. Is
Sure.
there anything known about smokers and COVID in relation to endothelial function? I mean, has smoking become an issue, or do we know nothing about it?
Great question. I mean, as you know, Miguel, smoking does impair endothelial function. It impairs endothelial vasodilator function. So I would imagine that smokers are, well, I guess you guys tell me, are you seeing more smokers in the intensive care unit, Faisal? Or Sachin, more acute thrombosis with coronary thrombosis with the smokers. What's the data on that?
Well, we are not necessarily seeing smokers being an exceptionally high risk. They can be, if the smoking led to pre-existing like a COPD picture emphysematous patient, then there are high risk-wise. And we have not seen that as an additive factor for increased thrombosis, at least in the critically ill patients.
In the cath lab, we see in the ACS population, obviously, we see a lot of smokers and diabetics. And, diabetic smokers, there are some studies which have looked at the thrombus burden. And when they've looked at, COVID, again, pre-COVID versus COVID era ACS patients undergoing PCI, the thrombus burden, the use of intracoronary 2B3A inhibitors and aspiration thrombectomy has been higher compared to pre-COVID patients or non-COVID patients. So there is clearly, evidence that, these patients with COVID who have an MI have a greater thrombus burden compared to non-COVID patients.
All right, so that's a very important point, and especially with the endothelium, I want to transition to a high-risk group that we manage also in our practice in the coming 15 minutes, which is the heart failure patients. I mean, these patients are really sick, and some of them are on mechanical support devices, LVADs, and they're waiting for transplants. And then you come where the whole hospital is full of COVID patients. And I'm going to ask Dr. Nadia Fida, who's one of our heart failure specialists, to tell us, how did you manage these patients, these sick patients who need biopsies and follow-up and blood tests during a surge? How did you handle this volume?
Yes, hi, good evening, Dr. Al-Mallah. Thank you so much for inviting me. Yes, it has, as you very rightly pointed out, heart failure patients along with heart transplanted patients who are supported on left ventricular assist devices, they represent a very vulnerable and high-risk group to COVID-19 infection in the syndrome, and very high risk to have poor outcomes subsequent to the infection. The management of these patients has been tricky. As Dr. Masud was pointing out, we learned the disease as in the past 2 years in managing these. I think the number one takeaway point is to teach the patients that the prevention of the disease is very important, especially in this vulnerable population who's especially on immunosuppression. So the rules that apply to general population are tenfold more important, perhaps far more important in this population. Basic things like hand hygiene and social distancing and masking and vaccinations. We also developed algorithms to triage our patients. We had to shift practices on virtual platforms as did across the spectrum of cardiovascular department. But also very importantly, we developed the protocols to screen these patients virtually, and to also have, as you know, they need surveillance visits, they need surveillance testing, as you mentioned, biopsies. Fortunately, at the same time, there is much literature coming forward to do testing for rejection on blood samples, like with AlloSure and AlloMap, to detect cardiac injury. So we started implementing those earlier on in practice. Our transplant patients, especially and the LVAD patients, we transitioned many of the visits virtually, depending upon what the patient's own risk is, a tailored therapy to them. If the patients are low-risk patients, they haven't had many rejections, then we postpone their we postpone their annual surveillance testing to post-surge and ship them in between when the things have calmed down in the hospital a little bit. So less exposure in the medical community, but on the other hand, we also have to manage that the patients don't present late, as Sachin was alluding to earlier, that in the earlier pandemic, when it started, the earlier surge, the numbers had declined because patients were not taking care of themselves because of the risk of that they were worried that they will get sick. So teaching important things to them, and also very importantly, I think in our population, the drug interactions are very common with all the antiviral medications. As now, the data has alluded to that we are not using hydroxychloroquine, chloroquine, some of the antivirals like lopinavir, ritonavir, which have QT prolongation, they can cause arrhythmias. They interact with a lot of medications that we use for immunosuppression. And finally, educating the patients that they should continue their medications. A lot of data that came on earlier because of the receptor affinity to the most commonly used medications that we use in heart failure, like enalapril, losartan, that are mostly grouped into angiotensin-converting enzyme inhibitors and angiotensin receptor blockers, and Entresto, which is a compound of sacubitril and valsartan. These are very safe to continue. In fact, there is harm in discontinuing these medications, and some of the nuances of immunosuppression, we have to tailor the immunosuppression. Again, there is no decades of literature on it. We have to tailor it according to their own burden of rejection and what their risk is. And a word on patients who are supported on left ventricular assist devices, that the only anticoagulation that is approved for them is Coumadin. So if they are sick that need with COVID-19 and need to be hospitalized, then they have to be switched to their anticoagulation because Coumadin interacts with everything else. So again, it was a team effort. We built algorithms, protocols, and we have successfully gone through several surges now taking care of these patients. But they are a challenging population to take care of.
And thank you.
If I could ask
sure.
Question briefly here, Nadia. A lot of the stable chronic heart failure patients, the secret to keep them out of the hospital is attention to little details, which you covered them briefly. But my question is, did you find during these spikes of the pandemic that telemedicine helped you? And what was your experience? This is, again, something that was new to all of us, the use of telemedicine. I'm assuming that you guys applied it. Any comments on what was your results and how useful did you find that to be?
Yes, that's an excellent question, Dr. Quiñones. So telemedicine has helped. It has helped a lot. I think all of us when we see our patients that we already know of and we are familiar with those patients, telemedicine helps a lot because you have familiarity with the patient. In new patients, it is a little bit difficult, and a face-to-face visit is probably more important. A lot of our patients have other data coming into us as well from testing, and a population that is on cardiomems helps a lot that we have their pressures already. And again, I think teaching the patients on how to use these platforms. In fact, in the beginning it was challenging, but I think there is a good percentage of patients who is still asking us, despite not having surge, if they can use the virtual platforms, because it not only reduces the exposure, they have more access to healthcare. I can see a patient on a weekend, not that I'm advocating that, but they do feel that they're more closer to healthcare system. So it has been a fruitful street, not only for physicians, but also for patients in terms of their reach to the healthcare system. But then, yes, of course, there is a subset of patients that find it difficult, but we find a way around it to do work with them. But it's less exposure to the staff, it's less exposure to the patients, but mostly for patients who we have familiarity with, it helps. It has helped tremendously.
Thank you, Nadia. I mean, these are a very vulnerable patient population, but also at the same time, when these COVID patients got admitted to the hospital and they're hypoxic, they start to develop arrhythmias. And we have a very nice review article from Dr. Paul Sherman and multiple fellows with him looking at the arrhythmias that come with these COVID infections. And what was the most common call, Paul, during these times, and how did you manage these patients, and what misinformation you had to face during this time?
Thank you, Dr. Al-Mallah, and thank you, Dr. Quiñones, for this invitation. It's really a pleasure to be here. Certainly, we'll get aboard of the arrhythmias during this COVID-19. And to understand this virus, the first surge and the second surge was significant bradyarrhythmias we're seeing. And compared to other viruses and infectious disease process, the sinus node was really suppressed and not correlating with the degree of sepsis or the degree of inflammation. And we have tons of bradyarrhythmias that have to be treated. And we use the physiologic mechanism of the own body to stimulate the sinus node. And if that would fail, then we try to use other drugs to stimulate it. But that was the first challenge that we had to deal with this COVID-19, was the amount of bradyarrhythmias that goes along with it. On top of that, then we start using more sophisticated treatments, like the use of hydrochloroquine with citromycin. That use prolongs the QT, and it's known that in patients with COVID-19, at least it was published in review, that at least 10 to 20% will have a dramatic increase on the QT. And if you have a patient already bradycardic, that superimpose the Q3 prolongation and put them at risk for life-threatening arrhythmias. And that's the least thing that we want to see in our patients. Once that drug was discontinued, then we passed to the lopinavir, ritonavir, and that combination, especially the ritonavir, has shown to produce more bradyarrhythmias. So we no longer are using that as a treatment for COVID-19, and now we're using the IV infusion like remdesivir, which also has been associated with bradyarrhythmias, but not as severe as the other two, and the interleukin 6, which is the tocilizumab, which is another antibody we use, and that really doesn't produce any major arrhythmias, for that being said. So that was our past, and that's what we were dealing so far. And now is eye-opening, and I want to share with my other colleagues, is the new oral antiviral that is coming. And it's called Paxlovid. And this is going to be our new first-line treatment of oral medications for COVID-19, especially with this Omicron variant that seems that it widely across the United States with hospitalizations on the surge, which is their current, present, and future. This medication is also a combination antiviral, but this medication is metabolized by the liver and has a lot of interaction with drug-drug. And if you read the fact sheet, any major antiarrhythmic drug that we use in cardiology, you will see an interaction, which is amiodarone, flecainide, propafenone, quinidone, and it has a red flag as contraindication because the level of those drugs or the viral will increase. Also the colchicine and lovastatin and simvastatin. So there will be a lot of drug-drug interaction. And I think it's important that we pass this information among our colleagues. So when they prescribe these medications through the ambulatory regimen, they are able to withhold these antiarrhythmic drugs or statins at first hand.
Thank you, Paul. This is very important.
So Paul, you have opened a big warning box there, because as these medicines become more available, it's not you and I who's going to prescribe them. It's the family practice doctor, the internist. So we really have to make this widely available to everybody. This could be a real issue if the average family practice or internist out there starts prescribing them without attention to those type of details. This is very important.
I would agree, Dr. Q, and I think that's part of perhaps telemedicine can help us boost the information and programs like you guys are doing here to alarm, because otherwise Dr. Faisal and myself, Dr. Goel will be dealing with ICU patients in toxic of amiodarone or propafenone or flecainide, or even the side effect from the own antiviral medication. So I think we should be careful. It has a contraindication at the moment, and we have no experience so far with this.
Dr. Sherman, the bradyarrhythmias that you described, that's a surprising phenomenon. What is the mechanism? Is it an increase in vagal tone or something else?
Well, that's a good question, Dr. Cook. So definitely there's an increase in vagal tone, and we're easy to differentiate those because they're transitory. That you see an increase and slow in the heart rate, and then it comes back again to a normal state. So, and they're usually associated with suctioning of the patient or doing something vagal stimulated. So those are real easy. So vagal tones are transient. So these are really prolonged state, and Dr. Faisal can talk about it, how patients are chronically in sinus bradycardia despite of 3 pressors or multiple pressors. So it's as its own, this virus has its own mechanism, especially in moderate to severe cases. I don't think you see this in very light cases, but the moderate to severe cases, this virus has a mechanism to suppress the sinus node in a way that we don't see with other viral disease or subsequent cases.
All right, Paul, I just want to ask you one question before we close. And many patients that are coming also to the clinics are coming with tachycardia post-COVID, and I'm sure you have no shortage of seeing these patients in the clinic. And the question is, why do you think they are like, what is the mechanism, and is there something we can do about it?
Excellent question, Dr. Al-Mallah. What about post-COVID? Because we have talked about past, present, but post-COVID, yes. We have a tons of PVCs, probably from some underdiagnosed myocarditis that has come. We have ablated and terminated, or otherwise deal with medical therapy and suppress them. So premature depolarization from the ventricle by far has been our biggest arrhythmia that we have deal with it. Also in the review that we do in your great journal, we accomplished to put some POTS mechanism, also some dysautonomia that we are seeing with the post-COVID has been increasingly reported. As the pandemic goes on, we have seen more autonomic dysfunction across, and patients being disabled and affected by this. So it's another topic is this post-COVID complication lingering. Those are the two majors that we're seeing so far and published.
So a quick question to Mouaz is, you probably have read everything that's out there about COVID. Do we have some general data when we're trying to talk to people to convince them to get the vaccine? one of the things I tell them is, it's not only whether you might die from the vaccine, it's all the lingering complications you could have later. Is there some solid data to quote on roughly what % of patients with COVID do end up with lingering complications that none of us would like to have? Is there a number we can throw at patients when we're trying to convince them to get a vaccine?
Yeah, so I cannot give you a number per se because these studies are ongoing and these are like mostly self-reported, and it also depends on the denominator. I mean, are you going to take patients that Faisal saw in the ICU? They're probably going to have much more symptoms than somebody who had an asymptomatic test and he was just routinely screened and found to be COVID positive. So there are a lot of variability based on the population that you study. But definitely we have no shortage. I can tell you every time I do a half-day clinic, there are 1 or 2 patients I'm seeing with long-term COVID. When we are doing imaging, we see 1 to 2 a day of long-term COVID. So there are a lot of patients who have some residual symptoms. The good news is that their symptoms appear to start to improve with time. So that's reassuring. And yeah, there are multiple like NIH-funded studies and others trying to understand the mechanism of that and what is the permanent damage from this. I'm going to pose the last question to you, Dr. Quiñones. What do you think our life is going to look hopefully after COVID from a cardiology practice when it is all over? Let's end it on a positive note.
Well, I think cardiology is probably one of the best jobs to have job security. I think that there will never be an absence of patients. What is going to be life after COVID is a great question, actually. In fact, it's a subject of conversation often in our social group with our friends, because there is a lot of concern now that, for example, we might end up having masks as a new normal. So I think the big question that we don't have the answer for is will COVID become so endemic like the flu, that with all of the scare that society has had with it now, we will be establishing a new normal, and will be 3 or 4 years from now, will we be using masks when we go to places or not? I think there is a lot to be seen. One thing we didn't have time to cover today, and by the way, I just want to thank everybody. This has been a wonderful webcast, and you guys have been, all of you, terrific. And Dr. Al-Mallah, you are a fantastic amphitryon for this. But one question one thing that we were not able to talk, we talk a little bit when we talk about acute MIs, is all the collateral damage of COVID. And obviously we talk about the high increase in MI, the delay in treatment of MIs, but as a society, I think we're going to be seeing a lot of collateral damage that we will be reviewing and writing about it. And that I think it's going to be one of the eye-openers for all of us.
All right, I think we're over the hour, and at this time I want to thank you all for joining. Thanks to all the authors who contributed. You can always, for those who are watching us, you can review the journal on the website and download the articles and go in more depth on our discussion today. And I want to thank everyone for their contributions. I want to thank you for your contribution today to this TV live session. And at this time, I'm going to close this session. Thank you for everyone joining us.
Thank you.
Thank you.
Thank you.